Well, it's really a pleasure to be here. I'm so appreciative of both Avidro and Oculus for sponsoring this great symposium. We're going to make my talk a little bit interactive, so I will be asking my panel, but maybe even some audience members, so just be awake. This is going to be on how we diagnose keratoconus and monitor the progression of keratoconus. Obviously, since this is a sponsored talk, this is just the safety information for the Avidro system. And I do consult for Avidro, as well as another company in the space, CXLO. So topography and tomography. So everyone's familiar with both technologies. You may, in your practice, have one or both. At our center, we have both a topographer and a tomographer. And topography, as you know, is basically reflection versus tomography. You have this shine fluid camera that rotates around and gives you a nice cross-section of the cornea, and as well as the whole anterior segment. Plus, it gives you both the anterior and posterior views of the cornea, which is the critical part. And for keratoconus, one of the key things that I learned quite early is that with tomography, you're able to get, you can image very steep corneas, which is critical for evaluating patients with keratoconus. So here's a patient of mine where we can get a nice image of the cornea with tomography, but look at the placido disc. So if you only have this in your practice, it really won't be possible to follow this patient for either progression or after cross-linking improvement or changes in their corneal shape. Now, obviously, we have to become experts at interpretation of topography and tomography, and there are obviously some patterns that we all learn about. But one thing that is true is that there is some subjectivity to all interpretation. But obviously, after LASIK or even PRK, you'll see this central zone of flattening, which is typically represented as blue, and then there's this rim of steeper area of the cornea. So this is typical for a post-myopic LASIK. And for hyperopic LASIK, you see the exact opposite. You'll see steepening in the very center. And I have had patients refer to me that have had previous hyperopic LASIK and wondering if they had keratoconus. And it can be a little difficult to sometimes determine if they have keratoconus, if they're progressing or developing ectasia. So you may have to follow them along, but it can get a little bit more difficult. Now, I'll ask my panel for the next question. So this is a 40-year-old female. What condition is this? So you can see there's some different colors on this Pentacam map. Dr. Ayers?
Well, whenever you see that, that steeper cornea and that, asymmetric topography, you've got to worry about some kind of keratoconus, or you got to worry that your patient wasn't looking straight ahead when they had the test done.
Right. So when you say keratoconus, can you be more specific, or?
Sure, either post-LASIK ectasia or you'd have a history probably of refractive surgery or keratoconus.
Right, so this patient did have a history of myopic refractive surgery, so we would expect that the cornea would be nice and flat like this, a nice central flattening. But you can see just coming out of that circular blue area, there's this area of red that's protruding forward. So this is a patient that's developing post-LASIK ectasia. So the pattern's a little different than keratoconus, but you can kind of start to see the difference between, how you can see the area flattening, a little green superiorly, which is kind of the former zone of a little steepening after the myopic LASIK. So anyway, this is just a pattern to be aware of. Here's another patient. This is a 14-year-old female. You can see again how quickly this patient can, how significantly they can progress over a year and a half. So this patient we diagnosed this patient with early keratoconus, but they didn't come back for 18 months. And again, the difference map is the key here, where you see again this massive change. It's not just the steepening below; it's actually flattening above. So it's a really significant change in the shape of the cornea. So again, you want to watch for these. And here's a 52-year-old patient with a suspicious topography. And this is an interesting one because, here I was a little suspicious, but I didn't really think this patient, just follow them along. I wasn't too suspicious. But look, this is 2011, and here's 2015. So, and the key is the difference map, where you see the significant steepening below, flattening above. Again, the change in the Kmax is 9.4, but it's not just the Kmax that got steeper. It's this redistribution, reshaping of the cornea that really impacts their quality of vision. Now, how about patients that have had previous myopic LASIK? So here's a patient, Dr. Rajpal, can you help me diagnose this patient? Do you think the scan on your left, how do you diagnose this patient? They've had previous myopic LASIK.
Yeah, I think you're right. Certainly that, again, very suspicious of a prior refractive ectasia. I'm sure you have something interesting to present about this, but...
That's right. So this is not the typical, so this is like a pellucid pattern. So instead of being the one I showed you before where it was kind of bulging forward, you can see it's almost like this crab claw appearance. This is a pellucid pattern after myopic LASIK, which you can definitely see as a pattern that can occur with ectasia. But what about the other eye? So anything worry you there? I mean, it looks...
Yeah, I agree. I think you have the central flattening, and then you have certainly a little bit of steepening in the periphery.
Right. Brandon? Anything worry you there?
Well, I always worry when I see ectasia in one eye, and the other one even has, you see a little bit of cylinder forming. I mean, when you look at the numbers, 40.6, 40, the color metrics are bringing out that little bit of astigmatism, but it makes me scratch my head and say, we should maybe watch this a little bit more closely.
And that's the key. And so, the patient, for this patient, the patient's right eye, perfect candidate for cross-linking. The left one, I think you can follow along. This patient at this point had a best corrected visual acuity of 20/20. So you mentioned just really important they come back for follow-ups. So let me just show you how things change in this left eye. So here we are with no signs of ectasia in 2012. And this is the patient comes back in 2017, just in April. So what do you think now? So you see, panel. There's a little bit of a change. Describe the change maybe. What are you seeing?
You're starting to see some inferior steepening there. And,
Right.
I mean, if this is repeatable, I would recommend treatment for this patient.
Right, so again, in the left image in 2012, it's not a perfect circle, but you see this blue flattening and it's a circular shape. But now you see almost like this green kind of tongue going in towards the center. And the key map I really like in this situation is the difference map. And this is, with the difference map, you can see there's this central area of steepening over the 4 years and 7 months. So this patient is developing ectasia. We're catching it very early here, but it's a difference map that can really help you determine that. Now, there's some other, yes?
How much fill would a patient like, say, on 2017 would that patient typically have?
Yeah, how much cylinder? So the question is, how much cylinder does this patient have? I think the patient's cylinder now has gone into the 1 diopter range. I don't recall exactly, but it's not a huge amount. But obviously, they had very little astigmatism, and it's increasing, and it's changing shape. And it's also a little bit irregular as well. So there's also, those of you who have the Pentacam, there's a new software that's developed by Michael Blinn called the ABCD Keratoconus Classification Scale, where A is this interior radius of curvature in the very center part of the cornea. And so you get different stages based on how steep the center part is. And then the B zone is, I guess the B of the classification is the posterior radius of curvature, so the posterior float or posterior area. And then he also puts in the thinnest pachymetry, as well as you can enter the best corrected visual acuity for the patient to try to get a classification of the keratoconus. And so there's a way to grade it. So with this patient, you can see this patient has keratoconus, pretty obvious. The thinnest pack is 436. The Kmax is pretty steep. And they could use the software printout. It's right in the middle of this. It's called the Pentacam topometric keratoconus staging, and you could kind of get a rating. And if you want to, you can either get a sense of where they're at now for the grading system and also follow them over time. And so the software also allows you to, at each visit, get a printout of the level of keratoconus. You can see this patient, multiple visits, has how it's changed for the A, which is the anterior part, B, and C. You can see how each time there's a measurement made, you can kind of compare how, each of these different levels, how they change over time. This is new software, and I think it may be interesting to those of you who, who have the technology to learn more about that. So in summary, I think the key is, screening patients. I think that we really need to be very suspicious and cautious. And when we do see patients that look suspicious for keratoconus, bring them back. Make sure they come back for visits sooner rather than later, and hopefully can pick up patients as early as possible. So thank you very much.